COVID case investigators that MDH is, has together and are doing contact tracing and other case investigation for COVID. Not all of those folks are MDH staff, but a good majority are. I know for DHS, some people are reassigned to COVID work, but it's certainly not the impact on the department like it is at the health department. So certainly this has a profound impact on all the regular work of MDH. So if you're trying to reach out to some programs or some people you know at health and they're not getting back to you, it's probably because they're just swamped with COVID and most people are doing more hours than they'd like to be doing. I know I've been remiss in mentioning Laura McLean. I think she was going to try to join the call today. And of course, we consider her part of the oral health team. And she has been deployed to COVID as well and is working on data and uploading it to the federal COVID data portal. So in any event, we just ask for your grace as we are journeying through COVID at the health department. We don't know this yet. So far, the oral health program has mostly escaped being reassigned to COVID. But I wonder as cases increase and as the disease burden is greater across the state, if there will be more of our time designated for public health work related to COVID. So it is my distinct honor to reveal the State Oral Health Plan 2020-2030. Yay! It's now in the final stages of development. We will be sharing another announcement when it's live on the portal or on the webpage, excuse me. You guys have all been a part of this collective work. It is built on the shoulders of the previous State Oral Health Plan, which really served as the launch pad for this iteration. It's meant to be used. We want this to be an organic, living, breathing document that helps to inform oral health work across the state, increase access, engage providers, and just like in general be something that we can say, look at, we all worked on putting this together and we're all working on implementing it. Let's see. So here's a peek at the inside. I know it's really little and I was having a hard time importing sections of the PDF into this presentation, but you can see the table of contents, and really what I want to call your attention to is on the bottom left and the middle to the bottom right is where we have our focus areas, and those focus areas, strategies, and objectives were developed. Concerted work was done by the Dental Services Advisory Committee, DSAC, and many of you also sent in public comment when we had an open period for that, and other groups that have commented on things that we need to lift up and make sure we shine a light on so that we can focus our efforts on those things. So the 5 main areas are the oral health infrastructure across Minnesota, access to oral health care for all Minnesotans, health system integration, medical dental integration essentially. Focus area 4 is disability, special care needs, and inclusion, and focus area 5 is data. Remembering that health literacy, health equity are understood to be wrapping this whole plan. That we believe that everyone has a right to information that they understand and is relevant to them, and that care needs to be culturally competent. So before I turn it over to Janelle, I'm just going to ask if there's any brief questions, or Dr. Cannell, if you'd like to make a few comments.
And anybody can put it into the chat maybe if they have questions.
Good afternoon, everyone. This is Prashida from New York right now. As Dr. Linda mentioned, I'm doing my dental public health residency. I would just say that this is a very emotional moment for all of us at MDH. And we'd like to thank all our partners, including Coalition, DSAC, and all of you who contributed to the plan. Again, like Dr. Linda said, this is a working document, and moving forward, we'll be connecting with you. We'll explore the opportunities of convening little work groups to take a deeper dive into some areas that obviously might not have been covered in details. So you would hear from us very soon. I think that's all, Dr. Linda. Thank you.
Great. So I'm not doing a very good job here trying to toggle between the Zoom meeting and the chat box and my screen, as you can see. So if there's any questions, I'll take them. Otherwise, I'll just hand it over to Janelle.
And I can monitor the chat, Dr. Maytan. If I see anything, I'll just pop in and say there's something.
Okay, great, thanks. Oops, now I did something wrong. There we go. Okay. Okay, Janelle.
Dr. Maytan, do you want to continue sharing your screen, or is your intention for Janelle to share?
I believe Janelle's on the phone, but so far we can't hear her. Okay, I'm gonna get rid of this.
Like we might need to unmute Janelle. She's popped into the chat.
Yeah.
Janelle is on the chat and she's asking to be unmuted. She's on 651-262-6908.
I've clicked to unmute her.
Okay, thanks.
Oops.
Hello, can you hear me?
Yay!
Hi.
Okay, good. I was getting confused because I have video on my computer, but then I always get like a staticky noise when I try to use the computer audio, so that's why I switched over to phone. So I'll do like a quick video just to say hi to everyone. And obviously, again, this isn't an ideal situation, but I've been privileged though to prevent exposure from being able to work at home. So then I am in constant communication with all of my MDH coworkers virtually. And then, as probably many of you others, people out there have also extended coworkers. So I don't know if you can see, here's my extended coworker right here, Jack. He's kind of sleeping on the job though, but he's good for support. Oh, let's see if I can you see him now? He's sitting in the back of the couch here.
No, but I think you should take some pictures and send them. We'll share them.
All right. I'll do that. Okay, I'll take myself off video just for the presentation. Okay. All right, so good morning, everyone. My name is Janelle Lamont, and I'm the Oral Health Surveillance Coordinator at the Department of Health. I'm also a health literacy professional, so I'm going to be talking about data and health literacy. Next slide. Yep, okay. So we will be holding a virtual health literacy workshop to be announced at a later date. Health literacy is so important but often overlooked part of effective communication in clinical care. We know that patient low or limited health literacy is associated with unnecessary trips to the emergency department, increased hospital stays, low adherence to treatment plans, and higher mortality rates. Health literacy also applies to dental care, including oral hygiene and frequency of dental visits, irrespective of income status. Next slide, please. Health literacy is also a component of health equity. Unequal access to clear, understandable health information can create health disparities. And in the workshop, we'll go over this diagram in further detail. Next slide, please. There are many definitions of health literacy in the peer-reviewed literature. I prefer the definition adopted by the Minnesota Health Literacy Partnership because it includes our responsibility as oral health professionals to provide patients and health consumers with information that is easy to access, understand, and act upon. Now let's look at an example. Next slide. So the coronavirus pandemic is currently attributed to over 67 million cases and 1.5 million deaths worldwide, with hotspots across the United States, including Minnesota, at 356,152 total cases and 4,005 deaths. Infections have been linked to workplace exposures, indoor dining and gyms, and small and large gatherings, both indoors and outdoors. Despite public health officials warning the public about the dangers of social gatherings, Minnesotans are still engaging in behaviors counterintuitive to their health and well-being. Health behavior change is one of the most complex and difficult interventions to tackle in public health. Measures like mask mandates and closing down traffic to non-essential establishments, though not perfect, are much easier to implement. In public health, we frequently encounter mass media messages that mislead the public. Here's an example from NBC's Law and Order Special Victims Unit. I happened to watch this season's first episode. I'm a huge fan of the show, but unfortunately I was both annoyed and shocked with what I saw. On the one hand, actors want to be able to show their facial expressions and might feel that wearing a mask muffles what they are saying. The show did attempt to showcase wearing masks, social distancing, and use of hand disinfectants and plexiglass room shields. However, these measures were not shown consistently and in alignment with CDC guidelines. I saw several examples of what I call freestyling, where actors were taking on and off their masks in the presence of others. On the top picture there, the district attorney is getting his temperature taken in the police precinct before entering, which is good, but he wasn't wearing a mask. And on the bottom picture, you can see an emergency room doctor with no N95 respirator or face shield when speaking with the detectives. He was also sporting a beard, which probably would not have been very good at providing a decent respirator fit. Next slide. I also saw several examples of chin strapping, also known as the diaper hammock. I thought it was kind of hilarious. The bottom picture there has a woman who's saying, "Hey, I'm not one of those Karens." Well, sorry, Karen, you are. Next slide. There are, of course, other gems in this episode, but here I'm showing you some of the scenes where I saw them using their masks correctly. Next slide. Another measure not being modeled correctly in mass media is safe disinfectant use. To the right, the EPA has put out a checklist for safe and effective disinfectant use. To the left, however, is a YouTube beauty influencer and CEO of Jeffree Star Cosmetics, who filmed a YouTube video that had 14 million views, showing him basically spraying Lysol over everything he was eating and drinking it. And in this picture here shows him spraying Lysol on some McDonald's fries before wolfing them down. I screamed when I saw that. It is our responsibility as public health and health professionals to counter misleading and inaccurate messaging and build relationships with patients, families, and communities so they have trust in science and medicine and see us as valid messengers of health information. Next slide. Health literacy goes beyond understanding the written word. but involves understanding and applying scientific knowledge, concepts, and skills to their everyday life. Here I've listed various concepts and terms that the public needs to know in order to understand how to protect themselves and their family members from the coronavirus. An example on the right shows that cloth masks and cone-style masks, when put to the test, will still disperse droplets and aerosols. That is why, when possible, it is important to social distance while wearing masks. Next slide. At a later date, we will be announcing a virtual health literacy workshop that I will be giving, and I hope all of you will be able to attend. These are some of the skills or competencies that you will learn at the workshop. Next slide. Now I'm going to transition into talking about the burden of oral disease in Minnesota. Ongoing data collection and public health surveillance is key to expanding our knowledge of what creates health, including understanding prevailing risk factors for oral disease, monitoring prevention strategies, and mapping out the areas and populations with greatest needs. Next slide. Data collection and public health surveillance is also meeting the populations where they are at, understanding that not one intervention will work for everyone. We need to identify and eliminate the structural and institutional barriers to achieving optimal health and provide the resources specific to the needs of individuals, families, and communities. Next slide. Public health surveillance is important for making informed policy and programmatic decisions. We use data to monitor the oral health of the state and to make comparisons to the nation's oral health when possible or against benchmarks such as Healthy People 2020. Next slide. In addition, we use data to assess common barriers to oral health and whether these barriers are being reduced over time in response to public health interventions. Next slide. We align our surveillance measures or indicators with those recommended by the Association of State and Territorial Dental Directors and Healthy People 2020, as well work with partners to develop other useful measures specific to our state. Oral health service use tells us the rate at which the population is accessing oral health services, as well as what population groups are accessing those services. Anecdotally, dental service use among the general population is about 50%. Here we can see that dental service use among the Medicaid population in Minnesota has remained relatively unchanged at about 30%, and that although less than 50%, the majority of Medicaid enrollees with at least one dental service claim was between the ages of 6 and 20 years. Next slide. Data to the left is from the National Survey of Children's Health. This is a phone and web-based survey that's conducted with a representative samples of families at the national level, but also at the state level. Here we can see that 8 in 10 Minnesota children under the age of 18 had a past year dental visit in between 2018 and 2019. Children under the age of 6 were 60% less likely to have had a dental visit compared to children ages 6 to 17 years. Data on the right is from dental claims from the Child and Teen Checkups program. Here we can see that 4 out of 10 Minnesota children 1 to 20 years of age had a past year dental visit in 2019. Less than half of the children were under the age of 6, a vital age group for developing good oral health habits. Next slide. Also, data from the Child and Teen Checkups programs tell us that in the Medicaid population, preventive dental services are currently underutilized. In 2019, only 38.6% of children had a preventive dental visit. This includes services such as an oral exam, x-rays, dental cleanings, etc. However, we have surpassed the Healthy People 2020 target of 33.2%. Only 17.2% of Medicaid enrolled children received an oral health service from a non-dental provider in 2019, such as fluoride varnish application. In 2018, fluoride varnish was added to the Child and Teen Checkups periodicity schedule, and data reflect a doubling of non-dental oral health service use from previous years. Although we cannot say for certain that adding fluoride varnish to the schedule is directly responsible for the increase we see, it is nonetheless interesting. Next slide. Now we will look at oral disease and disparities in the state. Next slide. Here are some summary statistics from our 2015 basic screening survey for third graders that we collect in-house. Here we can see that caries experience among third graders in Minnesota public schools was 49.5% compared to the US median of 55% and the Healthy People 2020 target of 49%. Untreated tooth decay was 16.6%. This is in comparison to the US median of 20% and Healthy People 2020 target of 25.9%. Treated tooth decay was 41.3%. And dental sealants was very high at 59.6% compared to the US median of 44% and Healthy People 2020 target of 28.1%. During this past school year, 2019 to 2020, we were in the midst of data collection on our third basic screening survey for third graders when COVID-19 hit and schools were subsequently closed. So our plan is to resume data collection, hopefully starting in fall of 2021. Just wanted to let you guys know that this data collection project is funded by Delta Dental of Minnesota Foundation and the Centers for Disease Control and Prevention. We've contracted with Children's Dental Services to provide the oral screenings. And this year, also differently, we've been collaborating with two entities. One is the Department of Health Office of Statewide Health Improvement Initiatives to collect height and weight data towards analysis of BMI among third graders. And we've also collaborated with the Great Lakes Intertribal Council Epidemiology Center, in which they will be collecting statewide data from tribal schools, and that will result in a tribal report. Next slide. This slide provides summary data on the basic screening survey for older adults. This was done in 2016 and measured the oral health of older adults living in a representative sample of 31 long-term care facilities across the state. Here we found that 42% of older adults had a dental care need, 41% had at least one tooth with untreated decay, 32% had at least one fragmented tooth at or below the gum line, 66% had partial tooth loss, and 25% had complete tooth loss. 3 in 5 older adults had fewer than 20 teeth necessary for eating, speaking, and socializing without the need for dentures. 42% of the older adults owned dentures, but 3 in 10 older adults with fewer than 20 teeth had an unmet denture need. So a lot of need in this population here. Next slide. We can also identify oral health disparities in the data we collect. The 2015 basic screening survey for third graders found that students enrolled in rural public schools were 30% more likely to have caries experience than children in urban schools. Next slide. We also see income disparities. Third graders attending schools with 50% or more students eligible for free and reduced price lunch program, which is a proxy for the concentration of low-income students in a school, were 60% more likely to have caries experience compared to students enrolled in schools where less than 50% of students were eligible. Also, data from the 2016 Behavioral Risk Factor Surveillance System, a telephone survey of adults 18 years and older in Minnesota, found that adults with a household income of less than $35,000 were 3.3 times more likely to have tooth loss compared to adults who earned over $35,000. Next slide. Okay, we also find disparities by race and ethnicity. This chart shows that Hispanic third graders in Minnesota were 40% more likely to have caries experience compared to non-Hispanic children. Next slide. We know from the literature that oral disease is associated with disability and chronic disease, though we are unsure if there is a cause-effect relationship at this time. Next slide. When we look at our data from the Behavioral Risk Factor Surveillance System, we see that all adults with at least one disability were 20% less likely to visit a dentist. and older adults aged 65 and older with at least one disability were twice as likely to have tooth loss. Next slide. Adults 18 years and older with heart disease were 20% less likely to see a dentist, and older adults 65 and older were twice as likely to have tooth loss. Next slide. Adults 18 years and older with diabetes were 10% less likely to visit a dentist, and older adults 65 and older with diabetes were 50% more likely to have tooth loss. So in summary, these data show an inverse association between dental visits and disability and chronic disease, and a positive association between tooth loss and disability and chronic disease. The implications of this is that we need to find ways to reach out to these groups to increase dental visits and improve oral hygiene. Next slide. We also collect other relevant statewide data. Next slide. This data is from the Minnesota Health Access Survey, which is a phone and web-based survey of households done every 2 years that assesses health insurance and clinical care. Here we can see the percentage of Minnesotans lacking dental insurance has decreased slightly over time from 32.8% in 2011 to 28% in 2017. Next slide. This data is from the MDH's Office of Rural Health and Primary Care that monitors dental health professional shortage areas. In 2018, there were a total of 124 dental health professional shortage areas throughout the state, including geographic-based health professional shortage areas, area-based on low-income populations, and facility-based shortage areas. Next slide. In 2016, Minnesota was one of a few states to add health literacy questions to the behavioral risk factor surveillance system. The data shows that adults with low or limited health literacy were 30% less likely to have seen a dentist in the past year. Next slide. Lastly, a shout out to the Minnesota Oral Health Statistics System, our state-based oral health surveillance system. You can access all the data I shared with you today and more on the Minnesota Data Access Portal. The web address is located on this slide. Thank you, everyone. I can answer a few questions now, if people have them.
Thanks so much, Janelle. If anybody has any comments or questions, feel free to pop into the chat. There's a question from Sharon Oswald. What does the future of funding for the department look like?
I'm not sure if I'm exactly qualified to answer that question. I know Prashita's on the line. Maybe she could take that on.
Can I ask for a clarification if people can hear me?
Yes, we can hear you.
Okay, Sharon, is this related to surveillance system or is it in general? So then it would be easier for Prashita or Linda or anybody from our team to be able to respond to your question.
General, if you can hear me.
Yes.
Okay.
I think I would request Dr. Linda to go first, and I would add my 2 cents to her comments.
There we go. You know, I think partially we don't know. We're not sure what's going to happen with the federal funding streams. We know that, you know, it's all money on deck for COVID, and I'm sure the financial run out of this is going to be long lasting. I was in a meeting the other day with other managers from the Division of Health Promotion and Chronic Disease, and this was the topic. you know, what do we do about our programmatic initiatives? What do we do in the face of uncertain funding? What impact does funding changes have on what we can and can't do? And of course, thinking that priority populations will be the most impacted by funding changes. So, I mean, at this point, we mostly don't know. Rashida, I'll turn it over to you.
Sharon, thank you for that question. This question comes up every day at MDH, especially with our passionate oral health team. We are trying to diversify our funding source, and one of the strategies has been to really look at medical dental integration. So we've been doing some behind the scene work in terms of pilot project. For example, we did a train the trainer sort of a pilot for patients with Alzheimer's, and we've also done a lot of community health workers related work. And we also try to look at what's going on at the national level to see if our focus should be opioid or like aging, you know, like just to make sure that our work aligns well with national priority that determines the funding at the national level. At the state level, I would say that sometimes I thought that, oh, if we had so much state funds, we would be blessed to be able to fill the needs at the local level. But because of COVID, I've also seen how state funds are significantly cut to be able to use that funds to meet the needs of the COVID pandemic in general. So like Dr. Linda said, we do not have a cookie cutter answer as of now, but we have been doing our best to look for new avenues where we could expand, not just as oral health, could be maternal child oral health, or it could really be coming up with an innovative medical dental integration project with a new workforce model that we have. So I think at this time, I just have this perspective, and I would like to ask all our partners to help us, you know, if you come across any funding opportunity, or if you have any strategies that you think we could adopt, and maybe we become more sustainable so that we can coordinate everything at the state level in a better structured way, please reach out to us, and we would really appreciate your support for that. Sharon, maybe do you have any recommendations for us, maybe?
No, I appreciate and understand that it's an ever-changing situation, but I was just curious if how vulnerable the department felt going into the coming year. But it sounds like you are thinking about it every day and doing everything you can. So it's helpful to hear from you. Thank you.
Sharon, and I think you and our program also have had lots of conversations where we are trying to maximize the little resources we have, whether it's an in-kind, for example, our people and with our partners. I think we've been so blessed to do a lot of things in kind from our partners. So sometimes I would think that, you know, it's not really funds that is needed in Minnesota, but just because of the passion of our partners and the support we have, we tend to get a lot of things done. So that does not mean we are comfortable and you're not looking for additional funding, but that's real, you know, challenge that we have. So thank you for bringing that up.
Great.
There's a question from Dr. Eileen Crespo. Janelle, you mentioned the disparities experienced for Latino children compared to white children in this state. Can you tell us, is there improvement compared to previous years? Are there specific efforts to better focus health messaging to vulnerable populations?
Yep, that's an excellent question. So right now, really the only data we have on oral health outcomes with respect to children is the National Survey of Children's Health for Minnesota, and then our in-house basic screening survey for third graders. So unfortunately, the way that like national data sets work, like National Survey of Children's Health, the sample for certain race ethnicities of children tends to be small. And so when you go to analyze that data, it's usually, you really can't say much about it, or it's not necessarily statistically significant. So it's kind of hard to track through that data set. our hope is that with the basic screening survey, with a concerted effort to make the sample more diverse, we'll be able to pinpoint and look at those disparities and see if there's improvement over time. And so with this third round that we'll be doing in fall of 2021, hopefully we'll be able to see a decrease in those populations. I'd have to look back at our 2010 data, but I want to say that when we analyzed that, we couldn't really, again, say that much about that data because it wasn't, the differences weren't statistically significant. But again, when we get our fall 2021 data, we'll have to see then what that kind of looks like. And I think the department in general wants to make improvements for how it collects data. Again, the limitation being that a lot of the data that's collected comes from the national level. And so those samples and the methodologies that are utilized are already prescribed. Things that we're collecting in-house, we are making more of an effort to try to draw, to do oversampling so that we can look at those race ethnicity differences. And then with respect to your second question on messaging to the vulnerable populations, again, I think that would be an area that we can work on through the Early Dental Disease Prevention Initiative or the Healthy Teeth, Healthy Baby program, as well as working with our communications coordinator, Erin McHenry, to do more focused outreach to those populations.
Thanks for the questions.
I think Lucas had a comment to add. Lucas, would you like to add
Yes,
a
sure.
comment here?
Either I can add a comment to the questions being asked by Sharon, or maybe when my presentation, it has some stuff there in my presentation, I can go there, and even with the that whether these high-risk population, what our plans are in terms of communications, that also is part of a conversation which I will be having. So either way I can go. Rashida, maybe I'll just go, and then I get to that slide, I can just talk about that. Because I don't think so I have too much time. I have only, I think, total of 15 minutes, including if people have at the end questions. Am I right, Leah?
That sounds about right. Yeah, we're
Okay.
we're looking good for time, and we have a little flexibility. So thank you.
Okay, really appreciate that. Thank you very much, everyone. Good afternoon. And it's always been excited to be part of Coalition. Whenever there are conferences, I've been there. Most of them, I have been with the oral health program for the past 9 years, and with the Department of Health also. And recently I have been working with Alzheimer's or CDC funding. We have received Center for Health Promotion. I have started working with them as a program evaluator also, and with oral health program also. A lot of you already know me. I have been trained as an epidemiologist, so I do work with the data and data sets also. Today, I will be giving update on the programming in terms of what we have been doing and how we have been working under the pressure of COVID and uncertainties. So next slide, please. Sometimes it's very hard to talk when you can't see people in front of you. It's very hard. Thank you. So as Linda talked about that our program also has been impacted due to COVID, but as soon as COVID hit, the very first thing which we did as a Department of Health for us was important that how we update the web page, because a lot of people who need some information probably go there and try to see that what is available in terms of dental services. So our communication coordinator with our other team member, she updated the web page. So it has a dedicated page. If you go there, you can see it has information about general public and also related to dental professionals. And I think we have been closely having conversations with Board of Dentistry and Minnesota Dental Association. Prashida has been in contact with them so that we have consistent kind of messaging on our site so that, and if there are things which we need to refer to Board of Dentistry or Minnesota Dental Association, you can see those links there on our website. The other communication which we felt was very important was to reach out to our dental sealant program providers, because we funded 11 programs in the past year, and we wanted to find out that how they were doing, how Department of Health would be supportive to them rather than become a burden on them. And we learned a lot from them. We really appreciate all those 11 programs who were working with us, and they were able to share what their situation was, and we tried to ease the burden of reporting because the reporting was coming, but the grant was ending in June, and we also supported them in terms of invoicing. The other thing which was very important, I really appreciate all the programs, is that they shared with us that how COVID impacted their service delivery and how to reach out to the population they really wanted to reach out. And that became a very important information at the national level, because CDC and ASTDD, which is Association of States and Territorial Dental Director, they were looking for that information so that they can create where they can submit to CDC that what's going on in terms of oral health and how crucial it is that oral health should be supported. So I really appreciate. So CDC used that information from our state also, which 11 of our grantees provided us. And when basic screening survey was impacted, which Janelle has already talked about, so I would not go into much detail, and how our staff had been impacted that Linda has already talked about, so I won't go into that detail either. Next slide, please. So as all of us said that as a Department of Health, we have been pulled in all the direction, but despite that fact, we try to be supportive to our programs. And what we did is that in the past, most of you know that we have been giving some funds to community water fluoridation. This year also we continued. There are two types of funding we usually give under that. One is the fluoridation equipment grant, which is more to a smaller public water systems to upgrade their systems because they don't have resources available. So we had 3 applications received and 1 we funded. And then for the hydration station grant, which is really a grant to promote oral health, make clean, safe water available to public, is one of the grants we have seen that is very popular. And this year we got 60 applications and 20 we were able to fund. And all these 20 who were funded for especially hydration stations are from independent school district, which was very interesting. That this is another component we are trying to work with the schools. So we were very excited that the schools were the ones who applied and received this funding. The other funding which we have been providing for last few years is a school sealant program funding. I know some of you may be thinking that why, when the schools are closed, why Department of Health is giving out these fundings unnecessarily. But if you really look at it, what was important for us, what we learned from what you shared, the impact of COVID and what were your plans, the programs, the providers out there, they came up with all these creative ideas that how they can provide sealants or oral health services to school children. And some of them, Sarah talked about it, and Smiles at Holly talked about it. And there were other grantees also who talked about it, that all the bright ideas they came up with. So that was the reason that we wanted to show that Department of Health is in support of those programs, which they want to implement out there. And we didn't want to say that the schools are shut down, you won't be able to go to the schools, what are you talking about? So that's why we didn't go with that route, and we went with that route, that how we continue supporting these programs out there who are trying to provide oral health services to school-age children. So that was the intent. So we have our application, actually the deadline was yesterday. We are contemplating on it that whether to extend the date for that or not, because some of the programs have reached out to us that they want to apply. We'll get back to you through probably through our website and email. We'll send out the email if we decide to extend the application deadline. The other thing which we did, and our school sealant program providers participated, don't move the slide please, is a audience analysis we did. We reached out to about 13 providers of school sealant programs who have been working in the state for a long time, just to learn the best practices, not only to learn best practices, but also to identify the communication tools which we as a Department of Health can develop so that those could be used for those programs, and also to give messages to general public and especially high-risk population, which Dr. Crispo was talking about. So we have gathered a lot of information through these audience analysis, which we are going to create some of the communication specifically targeting those high-risk populations. So I'm really thankful for those who participated for an hour-long interview for this. The report is almost kind of in a pipeline to get out, so you will be receiving that. And then move to the next slide, please. Some of the data which we received from the previous grant, I just want to quickly show, is that the 11 grantees who got the funding for the last year, they were able to serve about 22% of the total number of schools, and there were about 22% of the high-risk schools also they were able to do it. The next slide, please. And some of the data which we received from them, you can see here. I won't go into the detail of the data, but this is what we gathered from there, and we are preparing a report which we will be sharing with all the grantees. And if anybody else is interested to look at these reports, we will be happy to share with you. Next slide, please. Okay, this is what I want to talk about. Sharon was talking about that the funding, how the Department of Health is thinking about the funding. This is one of the things which I'm very happy to share with you, although I don't see that the funding is coming this year because of the COVID situation and the challenges right now in terms of funding is out there. But Blue Ribbon Commission, we know that this was established last year by governor so that Department of Human Services could provide better services, reduce the cost, and increase the efficiency of services. So Blue Ribbon Commission received number of applications, proposals, and two department our program, oral health program, we wrote one of the proposals, and we were shortlisted. And then also Minnesota Dental Hygienist Association also was shortlisted. So we wrote a combined proposal to the Blue Ribbon Commission under the health equity focus area, in which the title, you can see it here, is there is a typo, and even that typo is there in the final report also: improve dental access in public health care programs through coordinated statewide school-based oral health program. Through this particular proposal, we two together, Dental Hygienist Association or ourselves, we wanted a WISC model. You may know that this is the whole school, whole community, whole school model, which is very famous, and in our state also it's being operated right now in schools. So we wanted to bring oral health component into it through using collaborative dental hygienist. So that's where we work together with Hygienist Association. We submitted that proposal. We were lucky to be shortlisted and are being included in the final report, which went to the legislature in September 2020 this year. So at least we are happy that we have been heard as oral health, and oral health has been considered as important aspect of health and has been considered for that. The other thing which I would like to mention, the other place which I feel like that, although we are not getting any funding right now, but we have been part of these conversations, is that we have been also included into the governor's children's cabinet, and we are part of that group also. So hopefully that with all these works which we are doing, we may get some funding in future, but right now we don't have anything in particular we can mention that we have, except that CDC grant we have. And I think that's it. Linda, next is the slide is probably is questions. And if you have any questions, we'll be happy to respond. Our team is here. We still have 3 minutes, actually. Leah, maybe we can answer. Thank you.
Yes, thank you. Again, if anybody has comments or questions, please drop them into the chat. Dr. Crespo, do you feel like you got your question answered?
I did, and I'm actually leaving for clinic right now, so I can't stay on the rest of the conference. So I want to wish you guys an awesome rest of your afternoon.
Thank you.
Thanks, Dr. Crespo. We'll have this recorded and on our website so you can watch the rest of it later.
before I get in the car, my last question to Bilkis. Bilkis, can you tell us?
Sure.
Oh, can you tell me what exactly your input is on the Children's Cabinet? I think it's wonderful that they're including oral health there. And I was wondering, are you just attending meetings? Are they planning to incorporate oral health as one of their, objectives? Could you elaborate?
Sure. And please, Prashida, you can pitch in, and Janelle also. So when we wrote this WISC model and we were being approached to be part of this Blue Ribbon Commission, I think that's where we were being picked up by the news. And I think there are other people also who are closely working with Children's Cabinet. And I think they feel like that oral health is important. And that's where they started having conversation. They have not, I won't say that they have promised anything to us, but it looks like that the interest is there, because if you look at the WISC model, and especially with the oral health strategies incorporated into this WISC model with collaborative dental hygienists into the mix, looks like a very appealing idea and workable idea. So I think that's where the interest is, and if this gets into action, they can see that probably the costs can be also taken care of. I think that's where the idea is going, and they wanted to know more about it, maybe in terms of how it's going to be operationalized. And I think that's where the idea is. That much I can say. I don't know, Prashida, you or Janelle, if you want to add to what I just said.
I think I would ask Janelle to talk about it because she made the partnership possible. So Janelle, go ahead and talk about the story that led us to this phase today.
Janelle, if you're speaking, we can't hear you right now. I'm going to say that Jean Anderson.
Sorry.
That's all good. I'll say the thing about Jean Anderson after you're done. Thank you, Janelle.
Oh, okay. So, yeah, we had been introduced to Stephanie, and I'm blanking on her last name, but she's the one that kind of coordinates and does things for the governor's Children's Cabinet. And so we've kind of been building up a relationship with her. And my understanding from talking with her was that oral health is not a specific topic that the Children's Cabinet is supposed to be addressing. However, it is very much on their radar. They've heard a lot of things from the public that's a key area that needs to be focused on. And they've attended different presentations and conversations where I shared data on oral health. We had that joint, if you guys recall, that joint policy forum with the Minnesota Oral Health Coalition this past year, where we had invited different legislative and other policy people, both nationally and statewide, to attend, which a few did, which I was really pleased with. And so there they were able to, talk face to face with people, not only learning about the data and the needs, but talking with actual partners of the coalition on kind of what they see happening at the ground level and where the needs are. So I think, I don't know if I'm really answering your question, but I think through all these different joint efforts, we have been raising awareness with the Children's Cabinet as well as other policymakers around the needs for oral health. And so I really do see a bright future ahead for us.
I'd just like to add 2 cents to that. So to answer your question, we are attending the meetings as of now, and hopefully in the future, I think it looks like we might be asked to present on some oral health topics just to raise awareness. And like Janelle and Bilkis said, we think that there are lots of possibilities there, but at least at this time, we are glad that oral health made it to the sub-cabinet. That's a progress in itself for us.
Jean Anderson listed in the chat that the Senate Health Committee hearing is tomorrow at 10 a.m. It includes the Blue Ribbon Commission's report. And then she also popped in a link. So check out the chat box if you'd like more information about that. We'll pause again for just 1 second, making sure that nobody else has any more questions before we move on to presentation from Bridget Anderson from the Board of Dentistry. Deb Jacoby says, thank you, MDH, for keeping oral health in discussions and all the processes and committees. Bilkis Khan says, if you're interested to read our combined proposal, you may check out the Blue Ribbon Commission website.
And thank you to all our partners for always being there for us. It wouldn't be possible without all of you. I mean, like the trust we have and then the collaboration is just amazing. That helps us going. So thank you again on behalf of MDH.
Well, thanks to all of you guys. We really, really appreciate you and we love your leadership, and it's a great partnership with all of us. Thank you.
Sarah Wolf just says, thank you, MDH, for very helpful information. I really appreciate learning firsthand about COVID from all of you. All right, thank you, everybody from MDH. We'd like to welcome Bridget Anderson, Executive Director of the Minnesota Board of Dentistry. Bridget Anderson has over 20 years of experience in the dental field, including work as a dental assistant and office manager. She was Director of Regulatory Affairs at the Minnesota Dental Association for 4 years prior to her current position at the Minnesota Board of Dentistry. Currently, she serves as Executive Director at the Board of Dentistry, the agency that regulates and licenses all dental professionals for the state of Minnesota. Please welcome Bridget Anderson.
Hi, can you hear me?
Yes, we can, and we can see your screen. Thank you.
Perfect. Well, thank you for having me. I appreciate it. I've been a longtime member of the Oral Health Coalition, actually since it first started, so I'm happy to be here today. Today I wanted to just give some updates and kind of what's happening in dentistry right now, mainly focusing on some allied health professional things, talking a little bit about some of the COVID response and, you know, kind of going forward, you know, what that's going to look like and what dentistry is going to look like. And I really think it's important to discuss workforce issues as part of the work of the coalition too, because we're always talking about access and access to care. And no doubt this year, patients have been impacted tremendously with care that needs. So I kind of wanted to talk a little bit about that too, and kind of you know, talk about the COVID response and how that impacted patients. So I will get started here. Most of you, oh, where's my slide? I apologize, I thought I already started it. So most of you already know me. This is me. I've met most of you at Oral Health Coalition meetings, but like I said, I'm happy to be here today, and hopefully you'll get something out of the presentation. So I wanted to talk about an update on allied scopes of practice. I am going to touch on the dental assisting shortage that's being reported, and then also the COVID response in dentistry, as I mentioned. Here's our mission. I always like to start my talks with our mission. We really focus on the public health and safety piece. We do regulate the entire profession, but really that every professional meets the requirements for safe, competent, and ethical practice. I think that's really important too, as we talk about, you know, some of the access issues and some of the issues with Medicaid patients, especially accessing care, that, you know, we had a case actually this last year where we had to do a suspension on a clinic, or on 2 doctors in a clinic. And one of the biggest challenges was not, it was the patients actually calling and being displaced. And it was really, really unfortunate. And we understand that sometimes, you know, sometimes actions that we have to do because of the public health and safety piece, they're going to ultimately impact the patient's care because they have nowhere to go. So that was really challenging earlier in the year. And actually a couple clinics throughout this COVID response too, for various things. So that's our mission. So I wanted to provide you first the scope of practice changes and general updates. So one of the biggest things that we're doing this year is called a limited radiology registration. So we are pursuing rulemaking on this as we speak. So we're hoping that these rules will be published next year. 2021. Basically what we did is we took a limited radiology permit that we had that was not being used by more than about 5 people actually in the state. So it was very, very limited usage. And we're expanding it to include individuals that, that have appropriate training in dental radiology, but they don't necessarily have to be a nurse or a medical assistant or what we required before, or like a radiologic technologist. So they basically, they'll have to complete the board approved course on dental radiology. They do have to pass a national exam, although right now that is the DANBY exam, is the nationally recognized radiation exam for dental assisting. And then they have to pass the jurisprudence examination. They don't need to go through as many steps for licensure, but they do have to go through a lot of them, but not as much an education for continuing education. So this limited permit gives them an opportunity to enter the workforce as this limited radiology registration, unlicensed dental assistant, if you will, and that way they'll be able to take dental x-rays. They do need to also have this infection control education. So the course on dental radiology, there's, the University of Minnesota does a lot of continuing education. Any institution that has, that's a CODA approved institution has the ability to host this course in radiology, and we do have criteria that we've set for that. So we're really excited about this, and hopefully this will allow some additional individuals to be useful in practice and also help patients with access. We want everyone practicing at the top of the license. That's a really important point to what I'm going to talk about here next too, is that unlicensed assistants are being utilized, and we want them being utilized. A lot of the time they start as unlicensed and they end up pursuing education for licensure. So it's a way for them to get interested in dentistry, kind of get to know dentistry, and then pursue actual formal education. So the history of the PASS rule, I kind of mentioned, it wasn't being used very widely. It had some nuances to having equivalency education. The only people that were really using it in the state were a couple registered nurses that work in oral surgery, and then a couple of radiologic technicians that work at the U of M. So there really wasn't a lot of people utilizing this. Oh, they will be grandfathered, so it won't impact current licensees, or excuse me, current registrants with this registration, but it will expand it to others. The intent was really to address some of the workforce concerns. Like I said, it's kind of a method to bridge unlicensed individuals to kind of, pursue that further education in radiology, and hopefully ultimately pursue a full education in dental assisting. So the rulemaking, as I mentioned, that is in process right now. We actually, at the board, we have a large rulemaking project that we're working on that impacts, quite a few things. A lot of it's cleanup language, but this is one thing that is actually, it's a newer item, and this is a policy change item. So we are hoping that the rulemaking project will be done, as I mentioned, hopefully by summer 2021. It's definitely well in motion, so that's the goal. And then once those rules are published, they are, they take effect. I wanted to talk about unlicensed dental assisting because we get a lot of questions on this. And really, we want individuals utilizing unlicensed dental assistants as well, where, where they can be helpful or where it's needed. Once again, allowing the LDAs and the DH and the DTs and going all the way up to the dentist to practice at the top of their license. The dentists and dental therapists are responsible for personal supervision if the individual is unlicensed. And these are just some of the permissible duties. I wanted to kind of share this because some people don't know, and they ask a lot. We get a lot of questions on this, especially in a lot of community-based settings as well, because a lot of them are using both LDAs and unlicensed individuals. So they can perform duties not directly related to performing the dental treatment. So a lot of that is really referring to operatory setup, instrumentation setup, sterilization assistance. A lot of sterilization assistants are not licensed, but they're working in that realm. They are allowed to work in the mouth with that personal supervision, so they can retract the patient's cheek, assist with the placement and removal of a rubber dam. These are just some examples. remove debris by the use of vacuum devices, so that would be the suctioning, provide assistance, including the placement of articles and topical medications. So as long as they're under that personal supervision and doing the four-handed dentistry chair side with the dentist or therapist, they are able to provide that assistance in the oral cavity under that personal supervision. They also can aid dental hygienists and licensed assistants in the performance of their duties. Applying fluoride varnish in a community setting, that was added a couple years ago. The compliance with minimal requirements that they need to do is similar to the other registrant, which they have to have CPR and maintain CPR, and then they have to be compliant with the most current infection control recommendations. Typically, a lot of clinics do their CPR training in clinic and together. So I think that, you know, incorporating the unlicensed individuals is a fairly simple thing to do that, where they can all accomplish that and work together. And that's really true about the infection control requirements as well. And ultimately, the dentist will be responsible for their, you know, having the infection control training and making sure that this individual is compliant. The assistant cannot perform any other dental treatments or procedures on patients. So it's really working under that personal supervision. That's a big point with this one. If they do pursue getting the limited radiology registration, they would be able to do dental radiographs without personal supervision. So the dentist doesn't have to be chairside. I just wanted to touch base on collaborative dental hygiene too. You know, we talk a lot about it in these groups. I know that Colleen Brickle and others have done some great presentations on collaborative hygiene. I always like to mention it though, in everywhere that we talk, and I talk to the dental students about it too when I talk to them in their 4th year, just making sure that people are aware that, you know, this is available. It was amended in 2017, and you know, it's a written agreement between the dentist and the dental assistant, or excuse me, dental hygienist, and then we added dental assistant. And this is under general supervision for this. We amended it a few years ago and worked in a collaborative group to reduce some of the barriers to becoming a collaborative dental hygienist. So that since 2017, a lot of those barriers have been removed from the statute. Currently, I have 288 registered agreements as of this morning that we track on just a surveying system that we do. And then, so before, we always would talk about this, and we really weren't sure the registration for the agreements wasn't working properly because of an old database failure. And it was definitely less than 100 individuals, though, that actually had registered agreements. Like right now, like I said, I can visibly see the 288 registered agreements. We're hoping people continue to register them because unlike the dental therapy, dental hygienists are not required to register these with us. So that's not a requirement, although we would love them to keep registering them, keep sending them in, or keep doing the survey, because it helps us understand if this has any impact to increasing the amount of individuals with these agreements since the policy change in 17. And there's still some challenges with this, you know, with collaborative hygiene, just navigating that. I think that Normandale has done an excellent job of like doing education, information. There was a lot of collaborative partners, and I definitely recommend, you know, keep spreading that around, spread it to dental hygienists. I know that they talk about this in the dental hygiene programs too, to excite new hygienists to, you know, potentially look at collaborative dental hygiene. You know, even if they're working in clinic, even most of the time, if they wanted to do this even 1 or 2 days a week and get out in the community, that's really ultimately the goal. I wanted to mention too that sometimes people are fearful of, you know, trying new methodologies. You know, this was the case as well with dental therapy years ago. You know, worried about, you know, what would this look like, you know, as far as liabilities and things like that. And I really want to say too that from a complaint data perspective, dental hygienists absolutely have the least complaints out of all the, you know, licensees. Dental therapy, of course, as well, but that is more of a logistics because we don't have very many dental therapists yet in the state, but dental hygienists definitely have, very, very low complaints filed by patients. They have low adverse reactions when it comes to anesthesia. So I think that, just kind of putting that out there, easing some people feel that, there's going to be an increase in complaints or issues that are going on. We haven't seen that. I've yet to see that. And overall, dental hygiene complaints are very low with the board. And like I said, the purpose of the agreement's really getting them out into in the underserved populations, whatever that might look like. We also expanded that in the statutory language with that collaborative group. And then care can be given to the patients, students, residents, and things like that. So really getting them out into the community to serve these populations. And adding the dental assistant too, I think is a really, it can be a really good addition to having both of them practice at the top of their license and, helping each other and just furthering that collaboration. So I think that was a good addition. It's intended to ultimately address some of the dental access issues with receiving some of those hygiene and other services, preventative services. And just reminding that there is, like I mentioned, a difference between the collaborative agreements and collaborative management agreements for dental therapy. So I want to kind of cover, some of those things with just scope of practice and things like that. But now I thought it would be good to shift into this. This is kind of a hot topic type of presentation, just kind of what's going on in the landscape. So I kind of wanted to cover a couple of things that we're hearing a lot about in the community. I know that especially with community clinics and clinics that are serving underserved populations are having a lot of trouble locating dental assistants as well. I've heard that a lot from those settings. I've heard it a lot outstate, smaller private practices. So we're hearing that throughout the state. I do want to share though that looking at historical data as far as dental assistants to dentist ratio, there hasn't been a lot of changes. So my thought on this is that the demand is higher right now because they want, assistants practicing at the top of the license, utilizing more dental assistants in practice. So wanting to increase that ratio so everyone is practicing at the top of that. And that's including, for instance, when we incorporated dental therapy, dental therapists typically work with a dental assistant as well, chairside, and making sure that there is enough dental assistant to provide a ratio in the clinics as we kind of implement some of these new structures and some of the, dental therapy and some of these other things. So historically, there hasn't been a lot of change in that ratio. I just think that dentists now want to see that ratio increase and want more of the more dental assistants in practice. The enrollment in programs right now is looking good. I did check with some of the dental assisting educators, and it's looking good right now. They're trying to still recruit for ones that do have classes starting in the springtime, and so they're working on active recruitment there. There was a little bit of reduction in class size from some of the things going on through the COVID pandemic, not by the schools, but just by students not being able to commit to different learning structures and things like that. But ultimately, the programs are looking good as far as enrollment. So that's, that's good news. That's hundreds more dental assistants that'll be being licensed in the fall, or in the summer and in the fall of next year, of 2021. So that'll be several hundred more. We typically issue about 600 and change new licenses a year between dentist, hygiene, and dental assisting. So we're hoping to keep increasing that. One of the conversations that we're having and continue to have too is their entrance to the workforce. How do they get licensed? Dental assistants have several examinations that they need to take before licensure. So we're continuing conversations on that and, kind of how that's structured and what that might look like in the future, if there'll be any changes on any of the entrance to the workforce. So we're actively always looking at different things like that, how our policies work, how it impacts access, balancing access with public health and safety, like I mentioned, That's really important, of course, to us, but also not having, burdensome policy that, impacts access for no reason to the public health and safety. Not speaking of this, but just in general. So we're always looking at that in our policy committee and a lot of our committees, making sure that we're always really cognizant of how that impacts, how our mission and what we're set to do, how that can have impact on all of those things and ultimately the dental landscape. So we're always very mindful of that. The dental assisting shortages, as I mentioned, this kind of shows you that right now, like I said, the ratio hasn't changed much, but this just goes to show you how many people are maintaining active licensure, but they're not practicing in the state, or even some of them live out of Minnesota. As you see, there's 66 individuals that have an active LDA license here that don't live here or practice dentistry. Then there's 585 that are living in Minnesota, but they do not practice in, as far as an LDA. So I think that's just important to point out too, because when we look at goals, not just recruiting, of course, recruiting people that, want to change careers, or younger people, high school students, that's a big part of the recruiting, but then also, potentially enticing these individuals to return to practice, based on where, what their lives look like right now, or, sometimes people, actually a lot of people will take a break and have children, kind of stay home with them until kindergarten, and then as they're going into schools, which I know with COVID that's impacted right now when I'm talking about kind of more future, a lot of the time they will return to dental assisting or hygiene too. So that's kind of one of the goals too, just to possibly entice individuals and promote this to that it's really in need right now. It's making a huge difference in practice. It allows them to see more patients, and ultimately it's going to be good for a goal. And then the other goal too is to make sure that people are well aware of dental assisting as a career. Like I said, some of that recruitment on the high school level, and just getting people interested in the career in general. So now and I'll take time for questions at the end too, if that's okay, Leah.
Yes, that's good.
And now I wanted to kind of delve a little bit into the COVID, because all of this, even some of the things that I just mentioned, COVID, of course, response had impacted dentistry very, very, very deeply in the March, April, May, June timeframe. And I just want to kind of go into some of the things that that we were doing, that just really that we have to continue to do and be mindful of, and just kind of some of the changes that you'll see. So one of the biggest things was the infection control. We in Minnesota require compliance with CDC requirements and the use of PPE. One of the issues that kept coming up in the pandemic response is that the CDC was not timely with their guidance. And so we had to, as a board, basically put out our own guidance, and what we wanted people to do and what that would look like, as far as that, any type of guidance on infection control, PPE, engineering and administrative controls, all those things, because our federal agencies, frankly, they just weren't quick enough. This was moving very, very fast. People needed information. They needed, that was devastating. Dentistry primarily relies on elective care, as you know. And so even going down to emergency only care was just a lot of confusion. So really looking at things like this, making sure that individuals have the information that they need, that they, have PPE. We did have to work with the state emergency operations. At this point in time, we have redistributed over 100,000 masks, and that included N95, KN95, and so forth. We work, working with the state emergency operations to do that. I still have, especially a lot of smaller clinics and community clinics that are having some trouble purchasing. They have been reaching out to the board we've been collaborating with assisting them and helping them try to locate that. So that was one of the biggest hurdles that hit dentistry, was really the PPE wars. I mean, people were running out of gloves and just normal masks. So it was really a challenge, and that was, you know, kind of hard to work through. It's still, you hear probably in the news too that there's still some issues with PPE. You know, getting access, the costs are very, very high at the moment to a lot of, especially smaller clinic systems that don't have buying power. So that's just an ongoing challenge. And with a lot of the clinics that we work with, as far as, you know, the coalition and access clinics, I know that continues to be a challenge. So I do always encourage them to reach out, you know, at least trying to be a collaborative partner with helping people. The infection control infractions that we normally see are kind of some of these things, but the reuse of PPE, you know, we are allowing reuse of N95, just similar to the federal regulation, the federal regulations. But it was a really big challenge to get people to even, you know, change their, you know, kind of change their mindset on using the additional PPE, just added protections in their personal protective equipment. And some clinics, of course, you know, chose not to change anything. And that's where we're seeing some infractions with that. So during COVID, like I mentioned, the administrative controls, you know, with just different things, the way they're interacting with patients, you know, engineering controls, putting up barriers, physical barriers. A lot of open bay clinics decided to put up some physical barriers so they could continue to see patients in that setting. Like I mentioned, the PPE concerns and response was huge. Facility implementation plan. So what we did is wrote a template, a facility implementation plan, so individuals would at least have kind of a framework on where they need, you know, what they need to do as we started to ease back into full practice. So we assisted with that and developed that for individual clinics to utilize. Staff community exposure continues to be kind of an issue. We're not seeing any dentistry exposures, like exposures because of the act of performing dentistry. What they're seeing is just normal community exposure. So dentists or staff members that are, you know, having exposure in their community settings or, you know, different activities. And typically it's always traced back to a family member, a friend, or some sort of close exposure. We are getting a lot of whistleblower complaints with individuals violating, you know, the PPE and infection control. We are getting whistleblower complaints on things like that, which is to be expected in a situation like this. Some of them have merit, some of them don't. Sometimes it truly, a lot of the time, it was all the confusion created by some of our federal agencies because they kept switching their recommendations, which made it very, very challenging for people to keep shifting gears every few weeks. So we're working with that. We continue to work with that and work with clinics to make sure that they are up to speed on, you know, what is required of them. And I just include this too because in Minnesota we do have this mandatory reporting for infection control. So the person or the people that are reporting, they actually under their own license are required to report as well. COVID and patients, like I said, you know, bringing us back to that conversation, you know, we're always talking about patients, you know, getting their access to care, preventing them from accessing emergency rooms for dental care. That was one of the biggest fears when, you know, dentistry was not doing elective care because individuals, you know, just assumed or had this assumption that dental offices were closed or not seeing any patients or not treating emergency care, which, you know, we kept hammering that home. The Dental Association helped as well. The Department of Health helped like hammer that home, you know, different press releases and news to try to really direct patients back to their dental clinic because there were a lot of emergencies even in the first month, but that was reported by dental clinics. So that was a good thing that there was still a lot of clinics reporting at least continuing to see those emergency patients when they could. The board did receive patient complaints for them not because they can't receive care. So basically patients, complaining to us that dental offices can't do elective care or weren't doing elective care. So we were starting to get a lot of that, especially month 2. I think the first month when this kind of hit, people were like in a different mindset, like, okay, let's navigate this situation. I think during month 2, patients started to get a little bit more aggravated, especially ortho patient parents were getting aggravated, worried about the outcome of orthodontic treatments. And that's why we address that too with the facility planning, that orthodontia has to be addressed at that point because of potential for permanent harm. So we did have the patients complaining. One of the things too that was reported was an increase in incision and drainage in oral surgery clinics. There was a reported increase in that. Ultimately, of course, that's not what we want to see, but that's people that were, kind of in that emergency scenario and kept waiting. So definitely it was good to put that out there to patients, keep communicating that dental clinics are open and available for emergency. So I think that was really important. Now, on the flip side of that, there also, even on the national level, were patients concerned about returning to care. So some patients, you have your patient group of patients that are complaining that they're not getting what they want with their care, and then other patients are concerned about returning to care, which even on the national level and the state level too, we keep encouraging individuals to access the care that they need, understanding that dental offices are being responsible and being held responsible so that they can safely return to care, and that we don't want them postponing any of their needs if that's what they need to go return to care, whatever that looks like for them based on their individualized needs. Patient reporting, I'm getting some patient reporting on infection control concerns, not as many though as employees reporting their own clinics. And then we did have violations of the executive orders to not perform elective care, which made it very challenging for us because we were working as a community partner to try to, kind of assist the situation and support just as a community and as a state, kind of work through this situation. So made it a little bit challenging for us, kind of at the aftermath of that too, where we now have the violations of the executive order and have to, work through that as a board. So that just makes it more challenging when you're working through something is different to all of us as a pandemic response. So I just wanted to mention some of the exam changes. Of course, part of our role is, to serve as dental examiners. Some of the changes are continuing into 2021. So basically, what we decided to do is utilize mannequins and what Compadont, which is a special type of tooth that's used in those examinations. We decided to utilize that instead of patients for examinations, because it was becoming very challenging to have patient examinations when employing different requirements for social distancing, scheduling, even the logistics of the chairs and things like that. So we're also exploring more mannequin options with dental hygiene examinations. The OHSC we will continue to take, so the Canadian OHSC. We did not actually take a stance yet on the DL OHSC on the national level. So the 88 DL OHSC, we have not taken a stance on that at this time. So that one we're not allowing for licensure, but we'll continue to allow the Canadian OHSC for licensure. Another new thing that we're doing is a written examination for dental therapy or advanced dental therapy. So we're basically kind of grandfathering this examination in, where if an advanced dental or if a dental therapist takes the examination for licensure, for their initial licensure, when they are ready to become an advanced dental therapist, then they no longer have to do the written examination that we've been offering. So it allows them to expedite the process of them becoming advanced dental therapists. And also just taking one of the requirements off of that. Now, right now, as we transition, our advanced dental therapists will take the exam until we fully transition this over the next year or two. So that's just a new addition to that. We wanted a written OSCE type exam for dental therapy for initial licensure. We've been working on that for a while for initial licensure, but then, like I said, it takes that burden when they become advanced dental therapy. We're no longer going to require that. So it allows them to take it when they're just getting their initial license right now as well. Our portfolio audits to once again to reduce some of the burden that was kind of hitting people and licensees. We did postpone the requirements until the next reporting cycle. That's by an executive order, and that does include all of the health licensing boards, including dentistry. Interestingly enough, though, most people were saying there was so much free continuing education and different deals on continuing education that people were taking so much during that time. So I really feel that people are comfortable with their audit if they needed to be audited, but that's just an added thing that we decided that we would postpone those for individuals. Right now, we do not have a cap on how many CE credits people can do online. So even like today's course here with all of you, we're off. That's receiving continuing education credit today, and we don't have a limitation on that right now. So definitely encourage that. The CPR is postponed till March 31st, 2021. Once again, just to allow some time for more in-person classes. Although some people are offering just to kind of take that, take that off until spring 2021, allow people a little bit more time to schedule courses. We're not doing a new self-assessment for 2021 because in our current rulemaking proposal and changes that I was mentioning before, it's a very large project. So we also looked at our professional development rules, and we are no longer doing the self-assessment. So for 2021, we will not be issuing out a new one. Of course, if people haven't taken it yet, we are going to leave it up there, for them to take, but we're not doing a new one because once the rules are published, it will no longer be a requirement. COVID and vaccination. So actually, what time is it? It is 1:11. At 1:30 today, Governor Walz will be live discussing our vaccination plan for Minnesota. You've probably already known that healthcare workers will be in the first vaccinated, our category that's vaccinated. It's going to begin with long-term care and hospital workers, but ultimately dental workers will fall in that 1A category. 1B then will further, 1B will be essential workers, and then the 1C is going to be high-risk individuals over 65 or with conditions. There is a legislative proposal to administer COVID vaccine for dentists, and the association is leading that effort. Also, the board does support that effort, should they pursue the legislation on that, which it seems that they're working through that and working on that. That would allow, under our current statute, for dentists to administer influenza vaccines. It would add COVID vaccine under that current statute. One of the challenges with vaccinations was, getting supply, storage, especially this Pfizer one, I believe. Storage is really kind of there's a nuance to that as far as the cold that it needs to be stored. Just getting paid for vaccinating. There's a lot of these nuances, but ultimately the goal is, if the legislative proposal is adopted or a temporary authorization is adopted, that as a community, the dental community will work together to try to educate people on some of those nuances and challenges. Teledentistry, we saw a major increase in teledentistry exams, which was great. People that had never used teledentistry before were using it in all different sorts of ways. The HIPAA provisions were reduced a little bit to allow that more during this COVID response time. So I think that was a really great way for people to implement something new or try out something new. It was definitely promoted as one of those administrative controls, and it continues to be promoted that way, as far as less patient contact and really, getting patients in when they need to come in and things like that, and prioritizing their care. So triaging them, and then also giving the opportunity to screen them for any COVID questions. So I think I'm right on time. I hope I am. I hope I'm not running over time. I do have a few minutes for questions. Here's my contact. Definitely feel free to email me or contact me anytime about these things or anything dental landscape related. I'm happy to help you navigate that. Also with any legislation, typically when we bring forward legislation, there's a lot of questions on that in the community, and I definitely recommend reaching out to me if you have any questions. Although this year I'm not bringing forward anything significant, so.
Awesome. Thank you, Bridget. I have a couple of questions coming through from the chat. This from Bilkis Khan. Is the dental assisting shortage mostly in rural areas? Is the enrollment higher from rural areas, or are the new enrollees people of color?
So I don't have demographic information yet. I'm working on that with the META and some of the programs that we wanted to get more demographic information. I will say that in the metropolitan area, you are going to have a more diverse applicant for sure. In the Century and Hennepin Tech, things like that. The shortage, I'm getting dentists from all over. So no, not just rural dentists. I am getting dentists from the metro with the same issues as far as that goes. But yes, typically the enrollment in the programs in the metro area is going to be higher than outstate.
Another question, this one's from Dick Dirks. Are the active not participating numbers changing or about the same?
No, like I was kind of mentioning, and even like how it fluctuates, year by year, they're not changing that much ratio wise. So no, and even throughout the year, they haven't fluctuated much, even though I thought a lot of them would drop off, not wanting to practice during or after the initial COVID response, but that didn't really happen. I mean, we lost a few people went to emeritus active, which they probably would have anyway, just due to retirement and them wanting to do something else.
This question from Bilkis Khan. Do you have the number of dental professionals that have contracted COVID?
We have not received any reported that have contracted it through, like I said, through practice. As far as who, like dental health workers that have contracted it in general through community transmission, they don't have that data yet. And also contact tracing is very, very, it's, they've reported that they're fairly behind on contact tracing. So.
Mm-hmm.
Michael, and that's to be expected. It's virtually impossible. They were trying to do it a certain way when this started, but it's virtually impossible, for them to contact trace at the speed that they wanted, with the individuals that are, that they have, although they have redeployed a lot of people. So they're definitely doing it. It's just a little delayed as far as the data.
Dr. Helgeson says, thank you. A big thank you to the Board of Dentistry for such outstanding leadership during this pandemic. And I want to echo that too. Bridget, you did such amazing work this summer and spring.
I really appreciate that. Thank you, everyone. And I appreciate all of our collaborative partners too, because, we all did it together. So, and my staff is amazing, and they're absolutely 110% behind me. So, it just was a really good effort collaboratively. So thank you.
Does anybody else have any questions about the things that Bridget talked about? Thank you so much.
You're welcome.
Yeah,
I wanted to ask, I imagine that there's also a hygiene shortage. It feels like there's a hygiene shortage like there's a lot of temping happening and stuff like that, but is that true?
Yeah, we're seeing, we're seeing that people are also reporting the shortage of hygienists. Once again, too, I think it's really the demand. I mean, people want more hygiene, they want more assisting. Not that necessarily these ratios have shifted very much, but it makes you kind of think of it, just kind of the landscape that they are in, high demand. They're needed. Patients are needing them more. There's more patients trying to access them, and that's really great. But yes, we are hearing that too, a little bit more about hygiene as well.
This question from Sarah Wolfsha. Bridget, are you forecasting any significant PPE shortages on the horizon?
Yes, so I do believe that there is going to continue to be these shortages. They did report too, I think just a few days ago, on nitrile glove shortages, things like that. I mean, I think the most important thing is trying to access even small supply is going to be very much more effective than trying to, at the clinic level, order a very large supply, because typically that will be rejected when we start experiencing these type of, as if it goes on that way with the shortages. So trying to access small supply, collaborating with others, that was a big, we became like a distribution center during all of this. I mean, I'm a kind of person, a lot of you know me, you do what you have to do to get it done. So it was very interesting journey, but yeah, I mean, we did put out, like I mentioned, about 100,000. It helped people get kind of through some of those, times where they were really having trouble with access. And I continue to watch this as well, and I continue to, like I said, provide to individuals when needed or under emergency, things like that. So.
Sarah Wolfsha also says, thank you for all your help elevating dentistry so that our staff can get N95s that they need during this time.
Yeah, that's an important consideration, Sarah, because in order to even access that, I had to track emergency data and really say, hey, dentistry is stepping up to the plate here. We're diverting people from going to emergency rooms for care. But in the first month, there was 23,000 dental emergencies reported throughout the state to me. I mean, that's big, and that's important, part of that we collaborated too to keep these people out of the hospital.
This from Bilkis Khan. Is it true for Minnesota that hygienists are retiring at a higher rate than expected because of the pandemic? If yes, do you have any numbers to share?
So I'm tracking that data based on people applying for emeritus, inactive, and active. I will tell you that I am getting more hygiene emeritus applications in the last few months. And, like I said, we can look at, age, like would it have happened anyway? Do I feel, and this is my anecdotal opinion, that individuals that maybe were thinking of retiring or maybe in that 65 age range doing dental hygiene, yes. Do I feel that kind of increase some of those emeritus? Absolutely.
Great.
I just wanted to add something to the Minnesota Oral Health Coalition, together with the Early Childhood Dental Network and the MDA. We put together a dental assisting recruitment program, and we're hoping to get it out after the first of the year. We've got a graphic artist right now working on the pieces. It's a program that we were given access to from North Dakota, where they had a lot of success with it, and we Minnesotaized it. So we're looking forward to that.
And it's
I really am too, and I really appreciate that effort. Like I mentioned earlier in my presentation, that is so important too, is the recruitment factor and getting people really interested and excited about it as a profession.
Yeah, it's interesting. I know we need to move on, but the Early Childhood Dental Network, Jay Neubauer, they were talking about even creating some books and some fun things for really little kids about dental careers, so that when they're really small, they're learning, hey, I could be a dentist, I could be a dental assistant, things like that. So we're broadening the scope, and I think it's going to help. Well, that's good. Well, thank you so much, Bridget. I think people in Minnesota were used to such a high caliber of professional, whether it be from MDH or any of our nonprofits, and obviously from your office and from you. We were used to this high caliber of professional, and I think when I'm seeing I'm getting great texts from people, and everyone is so grateful to you for your leadership and just always going above and beyond and being someone really special. And we're very, very lucky to have you. So I just want to take this opportunity to let you know that.
Thank you very much. I really appreciate it.
So if we're good, we're going to move on to the last segment